It's a real pleasure to be here, and I admire all of you who are still awake and after two very exciting and packed days. So I've transformed my mandate, which was to talk about informing patients and an American vision, into the art and practice of oncology. Why? I happen to be a little obsessed at the moment about the art of oncology because I'm the editor for that section for the Journal of Clinical Oncology. And for the last year, I've had the enormous amount of fun reading essays from all over the world that reflect really the impact of the work on ourselves. I also think that the art of informing patients and the science of communication really are more about practice. We don't really have good level 1 evidence about communication practices. And a lot of what we consider expert opinion or guideline or the kind of material that makes it into our curriculum is really what we all think works best for us. So I don't want us to forget for a moment that that could change if any one of us has perhaps a better thought or a better idea about how we can help our patients. Most of my slides come from the New Yorker, and they're meant to engage you in dialogue. So to get us started, I'm right here and nobody acknowledges me. The elephant in the room is that cancer still means suffering or possible death to many of our patients. And that if we're going to talk about informing and communicating, we better be ready to tackle the very big existential questions, but also the very small and enormously important questions about what this is going to do to my life. What I've heard at the meeting for the last day or two are lots of stories about how inspired each one of the scientists here is, about their patients, about their real desire to help, to design trials that will answer clinically relevant questions. And in order to do that, the source really is the patient and the illness and the clinic. And I want to share with you some ideas about all of this. One of the really important and thoughtful contributions, I think, to this dialogue is this report that was just released by the Institute of Medicine in the United States. This is a board that gathers experts, reviews topics every now and then, and issues reports that will hopefully influence policy, maybe even funding, and certainly shapes opinion. I read it at the moment it was released. I did not have anything to do with this report, but I find it very energizing, and I want to share with you some of the most relevant parts. The report talks about living and dying in America now and highlights the most important aspects of what this care should be like. This is not just about cancer, but it certainly is relevant to the work we all do. They call for the delivery of person-centered care, and that is what we heard at the very onset of this meeting, that every single one of our interventions should really be patient-centered, and I'd like to reflect with you a little bit about what that really means. It has to be family-oriented. So not just patient-centered, but family-oriented, recognizing what most of us in adult oncology have absolutely forgotten, which is that it's really not a dyadic relationship of me and my patient, but the patient is a member of a family, and it's the family caregivers who ultimately will bear the burden of caregiving. Care is, in the States, unfortunately, increasingly fragmented, and demands on family caregivers are increasing. We have gone from, again, this dyadic kind of thinking to team-based cancer care, which is great because it brings in many professionals. It certainly may help the patient get access to many different people with different areas of expertise, but it's very hard to keep it all together, and the patient at the end needs to know who to turn to, who to talk to, and who to feel comfortable with. Palliative care is associated with higher quality of life, and I don't need to convince this group that studies definitely support that notion. Advanced care planning is essential, and that's where good communication skills are essential. We have to be able to sit with people and to help them think about what they would want or what they can imagine at a time when they are no longer able to decide for themselves, when they may lose their independence, which may be the one aspect of their life that they cherish the most, when they will not be at the top of their game or performing at their best. That requires time, skill, patience, an enormous amount of empathy. Systems must support clinician-patient communication. That's difficult. And I must say that just as we heard over this afternoon and yesterday about all the difficulties to getting regulators to do the right thing or to see the merit in certain practices, this is something that is often not supported by our system, by our practices, or by the reimbursement. Financial incentives must support integrated models of care, and quality standards are needed, and that's where we need more research. And we need, and listen to this one, public engagement to normalize conversations about death and dying. I think this is brilliant and fantastic and points the way to the many, many efforts that require imagination, require resourcefulness, and require really knowledge of your community. But that's, I think, a call to action for every single one of us. So let's start by analyzing what this report is talking about and what our work involves. It's really about our patients. This grainy photo that I imported from the web is a patient that I looked after many years ago. She was a brilliant anthropologist who died young of breast cancer, and about 15 years ago, Julie and I made a film together that explored our relationship, explored how we both endured the repeated treatment failures and how she was preparing to die, and that's what got me launched into this particular area of oncology. So over the last 10 or 20 years, the patient, our protagonist, has gone from being a victim to an empowered protagonist, active decider. I don't really know what the next decade is going to be like, but I'm starting to think that it's going to be even different. In the States, we just had a Facebook death of a 29-year-old who had a brain tumor and who wanted to share her experience with the world, including the timing of the death, which she chose and staged in Oregon, where patients can determine their own time of death and exactly the method. This is changing. We were reluctant to talk about these things. Now it's in our face. We need to acknowledge as physicians that there's a different preference for involvement in participating in making decisions. We can't just talk about autonomy and have patients and feel that all communication sizes fits every situation. We need to recognize that some very smart, well-prepared, educated patients don't really want to know everything about their disease. They may trust you and say that they've come to you for recommendation. And we may also need to recognize that there are some patients who perhaps are less trusting of the establishment, perhaps need more proof or data, and if we don't ask, we won't know. We've heard a lot about patient-reported outcomes and conceding, the power of who decides what's important from the clinician to the patient. So if we think about how far PROs have come, it also helps to tell the story of what's happened to patient care, especially in the Western world, for the last 20 years. We have validated the patient's point of view and proclaimed and named the patient the expert in his or her worldview. And in fact, we've acknowledged that they are our partner in research. We trust their grading of their symptoms. And if we trust that they can be a good partner in research, we surely need to trust them in the clinic. They are the final authority on their symptoms. At least where I practice, access to information is immediate, and patient activism has really changed the power dynamic between the patient and the clinician. And good communication is certainly something that we all aspire to. We want when we are on the receiving end of care. We want to give it to our patients. But the question that has always sort of haunted those of us who've been pushing to train doctors and cancer clinicians to better communicate is, what is the link to outcomes? Well, there's some link that's starting to emerge from studies that it does lead to better outcomes. Although I will say that it's still very tricky. I spent about 2 years with some research colleagues looking at all of the randomized controlled trials that tinkered with or modified the clinician-patient relationship and tried to link it to hard outcomes. After 2 years of work and thousands of studies, we only found 13 good randomized controlled trials. The effect was minimal, and in fact, when we submitted our paper, they asked us to redo the statistical analysis and turn our review into a meta-analysis, which allowed us then to find a very small statistical link that essentially showed that perhaps improving the clinician-patient relationship positively affected outcomes. But I think we're a long way from being able to say conclusively that good communication really leads to good or better outcomes. In fact, one of the funny stories that came from in my learning about this, for instance, was that in patients with diabetes, if they were with clinicians whom they perceived to be more empathic or compassionate, they were less likely to adhere to their treatment plan or to their diet. They felt that, so that it's not always the way that you think intuitively when you're looking for very hard outcomes. The family plays a very important role. Families can be resilient or families can be dysfunctional, and they may be that way before the cancer diagnosis. So when they're called to act and come together and make plans to help, to give up time at work or to give up, to sacrifice in other areas of their lives, they sometimes surprise you with enormous acts of love and altruism, and sometimes not. There are challenges for family caregivers who, at least in the United States, often have a full-time job. If you look at the number of hours they spend actually doing physical care, coordinating appointments, driving to appointments, providing assistance. So palliative care, it needs to come in as a family-oriented approach, and family meetings and assistance to the psychological and practical needs of family caregivers needs to be right up there with the plan of care. We heard today also that the community plays a place. I think Dr. Ripamonti talked about the fact that many patients didn't fully appreciate the resources or fully engage in providing support from community, but that's really important. So we have the patient within a family, within a community. The community standards often determine what people consider to be good communication, and all of this is greatly influenced by cultures. Those of you who work in clinics or hospitals where you have new immigrants know fully well that sometimes you have to ask who it is that you need to give the information to. You need to engage the support of all the family members. I'll tell you another story. There's a psychologist in Michigan, Terry Albrecht, who's done beautiful videos of what actually happens in consultation rooms when patients and doctors talk together. And she showed at a meeting this little clip where there was this man sitting there who had come in for his regular cancer check, and he was fine and in remission. And the doctor's talking to him about participating in a clinical trial of prevention, so he wants him to do this and that and the other. The man is silent. The doctor gets paged, leaves the room to answer the phone. Patient takes out the cell phone and tells somebody on the other end exactly what the doctor, he wants me to participate, da-da-da. He's talking. Doctor comes back in, phone is put back in the pocket, and the doctor says, "So?" And the patient looks at him and says, "No." So somebody decided who was not even present in the room. All of these influences, better that we know about them, better that we take the time to learn about them so we can respect them and work with the patient. The experience of illness is subjective. It's accessible through qualitative research, but we need to remember the subjectivity, and we need to distinguish, I think it's very useful also, between the patient's lived world of illness and the medical perspective. You may have a patient who is deeply, deeply troubled, even though you think she has a very good prognosis, and there may be something about her lived experience perhaps that doesn't jibe with what you think should be her outlook. That's the time when we need to dive in and ask. This is a picture of the cancer center where I work to remind me that all of this doesn't take place in a vacuum. It takes place within a system. Our system is increasingly complex with care that's fragmented, delivered at many different sites by many different teams, often with little communication. And so now, as a result of the problem we've created, we're trying to come up with new solutions so that you'll see there's a great interest in finding roles for community health workers, health ambassadors, navigators who are nurses or just members of a community who help and often are paid by the healthcare systems to help patients, to remind them they have an appointment, to explain to them what kind of testing they're going to have, to bring them to treatment, and different settings are using this to different degrees, and it's very interesting to see, to imagine that this will help. These navigation efforts have been documented to work in increasing access to cancer screening, and there are several interesting pilot projects and research that are going on to try to see exactly what role they will have in the future of cancer care. So in this case, the doctor is saying to the patient, wait, too much information. So it's information, communication is a two-way street. You may have a patient who's very willing to talk and a doctor who's not very willing to listen, or the other way around. As we heard before, during the afternoon, the experience of living with cancer or another life-threatening illness requires a variety of adaptations on the part of the patients, first adjusting, then coping through inner resources, through all of the resources that we saw beautifully displayed in the last couple of presentations, whether they're within the medical establishment, outside of the medical establishment, sanctioned as Western or official, or somewhere out there trying to find their right place. One of the greatest challenges for all of the patients and for us is to handle the not knowing. I think the handling uncertainty may be what often causes people to really be afraid, and it's that fear which often gets in the way to be able to adjust, to be able to reconfigure life, reimagine the future, and begin to cope in a way that can lead to joy in life and to handling it with strength. One of the most important tasks we have are in palliative care or in regular oncology care when the future is uncertain, is helping patients to reframe what they hope for and what they expect. And in order to do that, we need to have multiple conversations, be willing to listen, and certainly enlist the help of those who can help us both to address perhaps the patient's underlying anxieties, to make sure that they're properly supported, and most importantly, to provide the compassion, the support and guidance that they need. The doctor here is saying, how long did I tell you you had to live? Sometimes this changes, sometimes we forget. The trap often is that patients have expectations of treatments that are set way too high. That certainly happens at institutions like Mass General, where I work, at MD Anderson, where Dr. Cohn works, places where patients often come and say, well, there's got to be something else. And sometimes we get so caught up in trying to find the right treatment or the cutting-edge clinical trial that we sort of forget that in our efforts to deliver really personalized medicine, we're talking to tumors and not to people. And that's really could be a bit of a problem. So if you're able to have a team that has some continuity and knows the patient and knows the family, you'll be much better off. One of the greatest dilemmas that we face, of course, is also when to stop and how to have that conversation about stopping disease-oriented therapy and marking that transition to comfort or care. And we can be I don't want to get caught up on the semantics, but certainly there is a point in the trajectory of illness where that kind of judgment is really important. In the setting that we live in, the default is to treat. So one of the greatest questions that we should all have for ourselves is, in the setting where we practice, who brings up the conversation about stopping anti-cancer therapy if it's no longer working? Should it be the patient? Should it be the doctor? Because it's very easy to get up in a don't ask, don't tell, and to just get caught up in trying to solve problems. Well, I think you're kind of wonderful. This should be bidirectional. The oncologist should love the patient should love the doctor. But remember that this is hard work. And one of the things that we need to bear in mind, as we saw the number of patients with cancer that are expected to rise in the US and globally, is that there is a predicted shortage, and also that the rates of self-reported burnout on both sides of the Atlantic are staggeringly high. I spoke to Dr. Banerjee about the study she presented in ESMO, and she has a rate of up to 70% self-reported burnout among young European oncologists. And we just heard or saw published a study in the US by Shanafelt and his group a few months ago in JCO with a reported 43% of burnout among young US oncologists. So I'm not sure what the cause is. Give me 2 more minutes and I'll stop. This doctor says, if this doesn't help you, don't worry, it's placebo. Well, I want to bring up one very important point, because everybody's been talking a lot about placebo, and we use placebo in our clinical trials. The placebo effect is phenomenal. And I think we should celebrate placebo, and we should think about exploiting placebo. In fact, when you look at the doctor-patient relationship in the last few years, some people have dared say that the magnitude of a good doctor-patient relationship is the same as a good placebo in many studies. Pain studies, all of them acknowledge that there's going to be a placebo effect just from being in a study. So instead of dismissing placebo, I would urge all of you who are clinical trialists who are thinking about these kinds of interventions to actually think about how you can maximize the non-medical interventions, because there is definitely a placebo effect. So we've talked about palliative care. This is a great one where sometimes we're surprised by our outcomes. This doctor is making rounds and he says, he's one tough cookie. I've never seen anyone bounce back from an autopsy before. So sometimes we have great outcomes and we're not even sure why, but it's important. So my final slide is that I don't know how you view integrative palliative care, what your vision is, whether you see it as a series of supportive interventions that are handled by somebody who is exquisite and phenomenal communication skills delivered from beginning to end, or whether you see the input of many other teams coming along the way. But I think the most, the grounding effect is just to think about it from the point of view of the patient and the patient's family. This may work in a whole number of different ways. There's no need to have one model considered superior to anything else, as long as we think about all of those dimensions that I try to introduce today and think about doing each one of them as best as we can, and to keep that steady presence, whether it's from one person or a series of individuals, so that we can accompany patients from the time of diagnosis into survivorship or until the last few hours. Thank you.